Hello everybody and welcome to the Thursday edition of Video Clips, and we're just a month away from our fall conference. Usually I do announcements on Tuesday, but I'm doing it on Thursday instead. I like to change it up a little bit, keep myself awake, I suppose, and keep you on your toes. But in any case, our conference is just a few weeks away, and we have some amazing speakers. Dr. Richard Ablin, discoverer of PSA and the author of The Great Prostate Hoax. Robert Whitaker, Anatomy of an Epidemic. We have Kelly Turner, the author of Radical Remission. All of us are touched by all of these issues: mental health, PSA testing, terminal cancer. We have Janice Stanger talking about diet and hormones, Marielle von Lanthen talking about diet and inflammatory bowel disease. Great food, and who would not want to hang out with us for a weekend, right? So you want to be here in Columbus. So make your reservation. Tickets go up every couple weeks till the conference, so now's the best time. All right, picked a couple things to talk about today. Starting with pregnancy, which is actually a normal human function. Women are specifically designed and engineered to get pregnant, carry babies to term, deliver them, nurse them. But it is amazing how much this has all been medicalized. Pregnancy is now a medical condition that requires intervention and treatment. Now, I agree that medical monitoring of pregnant women can be a good idea, and it can reduce a lot of risks. The number of tests and supplements and interventions, it continues to go up. And the approach is almost like you can't do this without all this intervention, which is ludicrous. Well, one thing, blood tests are very common during the regular visits to the OB-GYN. One of the justifications for these tests is to look for iron deficiency anemia, which is very common in pregnant women in developing countries, not so much in well-fed countries. And one of the reasons why iron deficiency anemia is not real common in women in well-fed countries is because when women get pregnant, the body is so intelligent it begins to increase the absorption of nutrients like iron and calcium from the same number of calories in the same combination of foods. It's called selective assimilation, and all throughout our life cycle our bodies are pretty good at figuring out what we need today and how to get it out of the foods that we eat. Now, for women who have been shown to be a little low in iron, the studies are pretty clear that supplementation is not effective for most, and the common side effects are nausea and constipation. A lot of women are already suffering from that while they're pregnant, not so interested in making those things worse. Well, the U.S. Preventive Services Task Force has recently been issuing guidelines advising against a lot of this testing. I think that the task force is making a genuine effort to try and back off the medical profession a little bit. Their guidelines don't always go as far as I would, but there are a lot of them a step in the right direction. They state that there's insufficient evidence to evaluate the benefits and harms of screening for iron deficiency anemia in pregnant women. In order to prevent adverse maternal harms and birth outcomes therefore not recommended. Now remember, it's routine screening. Nobody disagrees with the idea that when it appears that something is wrong, that we try to find out what it is. But so the task force says this whole thing isn't applicable to women who are malnourished, have symptoms of iron deficiency, or hematological conditions that might increase their need for iron. So what the task force is really saying here and in other guidelines is that we should recommend tests and treatments for people who will benefit from them instead of everybody. And if medicine was practiced that way and whole healthcare was delivered that way, we would spend a lot less money, we'd hurt a lot fewer people. But therein lies the problem. This responsible approach is bad for business, so it's going to continue to go on. In the case of pregnant women, again, I support medical monitoring, and certainly abnormal symptoms are a justification for testing for cause. But pregnancy is a lot more enjoyable and less stress-inducing when women are not treated as if they are sick because they are pregnant, and they can, so I limit the medical interaction, limit the medical intervention, and let your body do what it was designed to do. Those are the best outcomes. Okay, moving on to another topic. There's extensive evidence for the use of cognitive therapy in depressed children, adolescents, and adults, and it works quickly, it's inexpensive, it doesn't require the use of drugs, and the recidivism rate is really low. But as it turns out, CBT is also effective for preventing the development of full-blown depression. Now, as more and more people are finding out about the side effects of drugs. And I just reported a couple weeks ago on the out-and-out fraud in the Paxil study that was designed, that ended up making the drug okay for children and adolescents. The researchers just manipulated the data and didn't report accurately what happened. So there's more interest, I think, in non-drug approaches. So researchers looked at the opportunity of using cognitive therapy as a preventive tool by randomizing at-risk adolescents to participate in a cognitive behavioral prevention program in addition to usual care, or just usual care alone. Those were the controls. Participants had a personal history of depression and at least one parent who had experienced a major depressive episode during adulthood. The intervention program included just 8 weekly 90-minute group sessions and then 6 monthly, every month for 6 months, group sessions, and then that was it. During 6 years of follow-up, subjects in the CBP group had a lower incidence of depression, which was measured in reduced depressive episodes and depression-free days than those in the control group, and also showed improved developmental competence. Intervention adolescents with a parent who was depressed during the intervention didn't benefit as much as those whose parents were not having a depressive episode during the intervention. The author stated that the study was important since adolescents with parents who have a history of depression are at greater risk of depression and functional impairment. Now, this leads a lot of people to think that because depression runs in families, it's genetic, when the more likely cause is learned thinking and behavioral patterns. The fact that this intervention improved results for at-risk adolescents with a depressed parent shows that the origin of depression is learned thinking and behavior patterns, and that those patterns can be changed. Think about this for a minute. Have you ever changed your mind about something? I only have 29,000 times since I learned how to talk, right? Well, if you can change your mind about all those things, you can change your mind about some of the things that are causing depression too. It's always better to prevent rather than treat disease, and so this is important. Kids that were considered at risk were able to prevent progression to full-blown depression. And notice that the program only went on for 8 weeks plus 1 session a month for 6 months. Not expensive, yet 6 years later these kids were still benefiting. So the challenge now is to figure out how to identify these at-risk kids in some type of way or environment that doesn't subject them to forced drugging, because that's the standard treatment now, is you take these kids and drug them rather than sending them to a cognitive behavioral program, which would be much better for them and much safer, because the drugs increase the risk. Not only do they not work, but they increase the risk of suicidality, suicidal ideation, and violence too. All right, that's all for today and for the week. As always, have a great week and weekend, and pass this on to anybody who you think you might enjoy watching it.